Hello and welcome to this new series of our Quantum Way Chronicles. This is a very special one. It's a South African series. I'm here with Dr. Rose Leputu. I hope I pronounce it correctly.
Absolutely right, Dr.
And you're a
Rose.
psychiatrist, and you have different caps in your psychiatrist job. But maybe my first question, Rose, would be, what led you to become a psychiatrist? It's not a common profession, and I bet it's not a common profession in South Africa.
Yes, very good question. My love for psychiatry started when I was still a child, growing up in a rural area of Amolepo in South Africa. We grew up in a community where there were a number of psychiatrically ill people in the community, and they were always mocked. They were always ill-treated by other community members. They were called names. And there was also this belief that they are bewitched. You know, people become ill mentally because of witchcraft. And that was a general belief. And when I started doing medicine, by the way, I always wanted to be a medical doctor. You know, from when I was still young, I always wanted to see myself working with people who are sick, you know, either as a nurse or as a doctor. Actually, initially when I was in primary school, I was talking more about nursing. But when I got to high school, then I felt I actually wanted to become a medical doctor. So now, as I was doing medicine, then psychiatry was part of the curriculum. And I said to myself, there we go. This is exactly what I'm going to do. Because I wanted to understand in depth what mental illness is all about.
And what have you learned?
And I have learned.
And I suppose that the cultural and the societal context of South Africa is specific. So how do you adapt this psychiatry, which comes mostly from Western countries, to maybe this context, and what have you learned?
Yes, I've learned quite a lot, and I've learned that mental illness is not well understood. It's complex. Even us, sometimes we get baffled. And in terms of cultural beliefs, we are still struggling with regard to that, especially in South Africa, where we've got diverse cultures. We've got diverse cultures. People still believe it's witchcraft. It's very difficult to convince them otherwise. But I've learned that there are a number of factors that play a role in the whole etiology of mental illness, and we cannot just isolate one particular factor from the others, because they all play a role. So there is biological factors, which talks more about genetics. There are psychological factors like childhood traumas, like not only childhood, rather, let's just say trauma as a whole play a major role. And also the environmental factors like substances, people abuse substances, the issues around the household, how people are being raised, getting different messages from, especially in a community of a South African people, where you get people living in one household. There's a grandmother, there's a mother, there's a father, there's an uncle, there's an aunt, all in one. So I think children tend to get different messages, and that also is confusing as they grow up. So those factors all play a role, and as a result, then later in life, putting the genetics in the mix, later in life, people do develop mental illnesses. So we still have a lot to learn, but the journey goes on. I'm still learning. Yes.
You told me that you were working a lot with. Now let's talk about, you work in a hospital, but in a special, with a special specialty. We're a forensic psychiatrist, right? And you also have a private practice. But maybe we could start with your what you're doing as an expert, psychiatry expert, and for the court.
Yes, I'm lucky to work in various fields in psychiatry. I do forensic assessments for the state. I do see private psychiatric patients on day-to-day basis, which is what I do full-time, by the way. And in private, you see different profiles of patients, from elderly to younger children who are suffering from conditions like ADHD. And I also have once every, I think twice a month, job at the correctional center, where I see inmates and people who are being, tried for various crimes. Yes, so and we also do what we call, we liaise with other medical professionals. We do generally ill patients who are admitted in our private institutions. In Limpopo, where I'm based, we've got 2 private hospitals there. So we also see patients that may become or may display either delirium, where they become confused, or psychosis due to the other medical conditions that they will be admitted for. And in private also, there are a lot of those people who are struggling with substances, that are abusing. There are various kinds of substances in South Africa that people, especially the youngsters, are engaging in. Yes. So that's basically what I do. I'm a general psychiatrist, not rather really I'm not yet super specialized.
So you take both children, adolescents, and adults?
Yes, I see everyone.
And what you encounter the most is substance abuse and depression, or what are the most mental illness or problems or issues that you deal with?
I would say, because in the state I do mainly the forensic assessments, so that's where I see a lot of the accused people that are coming for evaluation as to whether they can go to court or not, as to whether they are responsible for their crimes or not. So that is forensic psychiatry. In my practice, a lot of patients that I see are either suffering from depression, mainly major depressive disorder, others with bipolar disorders, and like I mentioned, the children who come with ADHD, and elderly, not so much. We do have elderly, but I think in the general population, we all know that the elderly are a small number. Usually, they're just not many. So we don't see a lot of them, but they do come suffering from Alzheimer's, dementia, or other forms of dementia. So, but a lot of my, let me say, the larger amount of my patients are those that are suffering from depression and bipolar.
And what kind of treatment can you give to people? And that, is it only like having, it's only medication, or it's also psychotherapy? And what kind of psychotherapy can you offer?
Well, even at medical school, when we were studying psychiatry from undergraduate level, we learned that the management of a person who suffers from mental illness is biopsychosocial, meaning you have to combine both the biological treatments with the psychological interventions and also the social interventions. And in addition, where I work, we have an occupational therapist, because working with private patients, a lot of times you're working with people who are employed, people that are expected to go to work at some point after treatments have been implemented. So they need to understand as to whether this person will still be able to do the same job he or she was doing or not, or should they become placed somewhere else, given alternative jobs to do. So so we work in conjunction with all those healthcare professionals, the psychologists, the social workers, and the occupational therapists. So medicine alone cannot get your patient to a state where she or he is fully functional and is able to be reintegrated back into their profession or back into their community. So it's important to put everything together when dealing with our patients. Yes.
And because we are trying to promote many different psychotherapy approaches with Quantum Way, I'm wondering what kind of psychotherapy are mainly offered in South Africa nowadays.
These days in South Africa, a lot of times I'll speak about myself and my colleagues. A lot of times people dwell more on CBT, cognitive behavior therapy. That is the one that is commonly used.
And what about dance therapy or art therapy or other forms of therapy that can meet the body, but also the social, maybe the social side, or bring maybe into therapy the culture?
That is very, very important. I cannot overemphasize how important play therapy, we call it play therapy, its role is in dealing with psychiatric patients. It's just unfortunate that mostly the play therapies implemented where children are involved, but we don't use that much with the adults. Yeah, it's we don't use it much with the adults, and even when it's done, it's in a group fashion. It's only done in a hospital setting, like in a psychiatric hospital setting, and it's usually conducted by the occupational therapists. So because they do vast types of therapies with the patients during the admission. But the problem is when the patients are discharged, unfortunately, I don't think that will still be followed up. So yeah, that could actually help a lot.
But it's not common for adults. It's really more
At the
CBT.
Yeah, it's not commonly applied.
Yeah.
Yes, it's not commonly applied to adults, but I'm not saying it may be so important, because remember with psychiatric disorders, people are tense. People are tense. They need to get it to a place where they are more relaxed. And such therapies, actually meditation, dance therapies, those will actually help a lot, because with tension, then the depressive symptoms become actually exacerbated. So we need to deal with, like I said, when you deal with a patient who has a psychiatric condition, it's important that you deal with all the aspects, all the etiological factors that play a role in a patient becoming depressed or even worsening, or not even responding to the treatment, because you could be given treatment, adequate treatment and everything, but if you're not taking care of these other aspects, then you are likely to not have a very good outcome.
You're working a lot. So psychotherapy would be CBT, and then you have the biological, and when there's the chance of an OT, that's perfect, and maybe a social worker also. All those models come from the Western countries. How do you adapt to another culture, which is obviously what we have here in South Africa? Do you think that those models like the DSM-5 or those CBT concepts adapt to a country like South Africa, and maybe to Africa in general? What's your view? What's your point of view?
My view is that in a place like in the South African context, to be honest, a lot of what is written in the books, what is described as the standard, or the, what do you call it? The gold standards of therapy, they lack somewhat, the effectiveness that a typical South African may need, because they are, like we said earlier, our cultures are different. Our cultures are different. Our belief system is different. We still find people going to both the psychiatrist and the traditional doctor. Some patients are brought into my practice by a traditional doctor. I'm bringing them for treatment, and I'm taking them back to where I'm treating them. So people are still doing that. So I guess the disadvantage when it comes to how mental illness is defined or explained in the DSM is that it's not all encompassing. There's a lot of gaps because our culture is completely different from other cultures out there. So I feel there is still a gap. There's still a gap in terms of what we do for our patients in South Africa, and what kind of therapies apply to South Africa. Because, yes, South Africa has got different categories of trauma-related problems. We hit COVID in 2020, and that's when we saw that indeed our cultures are very complex, because people now are still suffering from the fact that they could not even remember during COVID, a person would pass on. Today in our culture, you wait for like 7 to 10 days before you prepare for a burial. But COVID brought about a different scenario where people had to prepare for a funeral and they don't even have to see the person that they're burying. And that is still traumatic even to this day. And there is no kind of therapy that I know of that we can actually apply to such patients so that they can recover. They're still battling to recover from such type of traumas where they had to. Others are still like, sometimes I don't feel like my relative, my uncle, my mother, my aunt, my sister actually died. When I look at the hospital, I'm still thinking, he is still there. One day we are still gonna see this person walk in. They still have that hope.
Because you didn't do the proper,
because there was no proper the way the culture expects them to do it. They didn't follow all the cultural what do you call the cultural
impact?
Not
No.
the impact. What procedure? Not procedure.
Traditions or
no.
Okay, we'll come back.
We'll come back to that. Yeah. So because they didn't follow all those, they didn't have time to even inform their ancestors that here we are, this person has passed on, this is now a problem, please we're releasing the body, please accept her on the other side. They didn't go through all that. And now it's traumatic for them. They are living that trauma even today. And therapies, let's say the traditional therapies may actually not be effective enough to deal with such patients. And the other things that we know in South Africa is, we're battling as a country with socioeconomic problems. Poverty is a serious problem. Unemployment is a serious problem. The gap between the rich and the poor, it's a problem. The middle class, we call them middle class, but they are not really middle class. I think they are just
a little less poor.
A little bit,
a little less poor than the poorer.
Poor than the poorer.
Yeah.
Because when you look at the household income, you realize, really now, this is not money that any household should be getting and surviving on. And unfortunately, or sadly, you find that those people in the middle income bracket are not qualified to apply for things like government bursaries, to be able to take their children to school. They don't qualify for the RDP houses, as we call them, those 2-bedroom, 1 kitchenette, and small lounge type of houses that are built for free for the poorest. And I believe that everyone, even the middle income people, should actually qualify one way or the other for something like that, be it subsidized by government or something, but they all do qualify because the poverty is palpable. It's very palpable. It's glaring, and it's a bigger problem, and that is the cause. In essence, it's a cause for a lot of ailments that we see in our psychiatric practices, because we are seeing a lot of patients coming depressed. They are bothered by their children at home because they are unemployed. I mean, if you live with a 27 to 30-something-year-old child in the house, this child cannot go anywhere. He is a child, she is a child, because it's bound to stay at home with you. Where else can this person go? And they start clashing with each other, and environment becomes not so pleasant to be in. So those are the commonest cause of the triggers, the commonest cause triggers of mental issues in our communities.
Mm. And I guess this middle class and the poorest, they are not the people who come to your to psychiatry to get treatment, or how do they access those medical treatments? Do they go? Do they have access to it?
There is the middle class. Most of them are on medical aid because we do have, as you call it, medical insurance offered by government for all government employees, and then others to afford insurances from other private companies as well. The poorest, those are the less poor, the so-called middle class, the less poor, they are mostly on medical aid because they are working for, most of them are working for government. And then we have the poorest ones who cannot even afford a medical aid or medical health insurance. So those are patients that will be seen in the state sector. There are psychiatrists working in the state sector. Like you said, when we started off this discussion, there are very few psychiatrists, and we have that serious problem in South Africa where psychiatrists are not easy to find. So the state has got few psychiatrists that are there. I do help once a week, every Wednesday, and but with the forensic, so I relieve them so that they can be able to see the other general patients. So access to help, it's a challenge. It's a big challenge.
Yeah, and why do you think there are not enough psychiatrists here? Is it a problem that people get trained here and they go in foreign countries, or is it because they are not appealed to do psychiatry, or because what are the reasons?
I think generally there are few specialists in South Africa in general, not only in psychiatry, but in general. There are few specialists. And I think the problem stems from the fact that there were very few medical schools. When I was training, there were only, how many medical schools? It was UCT, Medunta, UP, Wits, UOFS.
Yeah, 5.
Yeah.
For the whole country.
For the whole country.
Oh.
Oh, Natal, sorry. I forgot
Okay,
Natal.
6.
6. So there were 6. Nowadays, at least there is one. There's number 7, Limpopo. There's Walter Sisulu. There's Potchefstroom, I think, if I'm not mistaken. So there is a bit of an increase. So we'll see how it goes. And there are those that were trained in Cuba. So government was able to send other students to Cuba for training. That is one problem. The other problem is entry into medicine is not easy. I think that is another factor. And maybe the third factor would be that they call it a noble profession because not everyone is interested in dealing with people who are sick. Not the interest as in they don't want to see people getting better, but they don't have what it takes to deal with sick people.
Is it because sickness is weakness?
Not
No.
in that sense. People don't want to see blood, first of all. Like, my husband is like that. He sees blood, he's gonna stand very far from anyone who's bleeding. He doesn't want to see anyone injured and bleeding. It's his problem. So I know there's a few people who are like that. I think generally. I don't know if they...
So going to medical school is not a natural, how do you say, people don't go naturally to, they don't want, it's not like I want to go to medical school. It's very,
yeah,
very few.
it's very, I think the problem starts there. There are few people who would really have passion to study medicine.
Okay.
Generally.
Okay.
Now added to that is the fact that even those who would wish to do it may not be qualified to do it. And then generally we have fewer medically trained professionals in our communities in South Africa, and therefore we end up having very few specialists, because then from that pool of general practitioners, then you have to draw out a pool of those who are interested to further specialize, and not all of the qualified medical doctors would like to specialize for various reasons, of course. And one of them, again, is the fact that we are very poor. And once you have completed a degree, everyone is looking up to you for something. And now the time to go specialize is not really, you see, you don't have the luxury of specializing, because now there's my brother and sister and niece and nephew and whoever that still need to be pushed and be taken to tertiary and be cared for, build your parents a house. So people we end up just becoming general practitioners and working, because to become a specialist means you must go back to studies. You see, must go back to school.
Yeah, and you don't earn money.
You do earn, but it's not a
lot.
A lot. You do earn as a resident, but it's not satisfying, and you need to also share your time between books and other people who'd like to start families as soon as they have exceeded the medical school. So there are a number of factors. And with psychiatry, the other one would be that, psychiatric patients, perhaps if we talk about the severely affected psychiatric patient, hence the stigma, are not, they're not a group of patients that people would wanna work with. Yeah, they become aggressive sometimes. They can become moody and irritable and agitated. So some people might not really want to do psychiatry because of such.
We talked about the trauma during COVID, which was very specific to your country. We talk about substance abuse. We talk about the problem that people live all together and have many different messages. And we didn't talk about apartheid and this. Do you still find that there are some transgenerational trauma linked to apartheid and to this specific country? Or you don't encounter that in your practice?
Not directly, I may say. I think what we have explained, everything that, all these factors that we are explaining are as a result of apartheid. So this very low socioeconomic situations is because of apartheid. The fact that people need what we call RDP houses is because there were problems during apartheid, and so the apartheid itself is exactly why we have this gap between people, because apartheid was segregating different tribes in South Africa from each other, and those that were agreeing to the laws that were put or were endorsed were getting more benefits than others. So I think what we are describing and what we are seeing right now are the effects of the apartheid itself. So the patients coming to us are no longer talking apartheid because it's a thing of the past. I mean, we've been in democracy for the past 30 years, but they will present those problems as what is current to them at the moment. But those are the results of what South Africa has been through during the apartheid time. If it wasn't for 1994, I don't think I would be sitting and here and chatting to you and having an MBCHB degree as a profession and a speciality in psychiatry. But because of the fact that apartheid was ended and I was able to get into a medical school, irrespective of the fact that I did not have the money to pay for varsity. But at least government was taking us in and putting all resources together to ensure that we study for as long as we've passed matric. So unfortunately, other people were not so fortunate like myself.
Going back to your role as a forensic psychiatrist, you make forensic assessment.
Yes.
So you assess, evaluate if a person is able to be in court or is responsible of their acts. What are the main difficulties you encounter in this kind of job?
The difficulty is first and foremost the safety issues. Because some of these people are not necessarily sick but malingering symptoms of mental illness, and they're very dangerous criminals. That is the first thing. But other than that, it's a job that I enjoy because we do see a whole lot of mentally ill patients being sent. Let me say 1 out of 10 patients could be that one person who is just malingering and is not sick at all. But the rest are genuinely ill people. And I think the challenges of access to treatments, that is so difficult. They end up not getting their treatments on time, or they go to hospitals, the treatment is not available, or the transport to go to the hospital is too expensive, because people are living on social grant, which is like 2,000 per month, and that should cover a whole household. When we talk about the very poor people, So now those challenges lead to them not complying to treatment. Then they end up being sick. And when they're sick, they will become irrational. They will destroy property at home. They will assault the, the relatives at home, and then they lay charges against them. The police will then arrest them, and then they are then sent to us. And the same relatives who lay charges are the same people who'd go to police and say, by the way, to the courts and say, by the way, this person is taking medication. He is not mentally well. And we know even on the day he was doing whatever he was doing, he was not okay because he missed his treatment, and then they are brought to us. So, but you just get to realize how challenging life becomes amongst people out there. Now, the other issue is we also see a lot of sexually assaulted victims, and mostly children younger than 16, younger than 16. So, and that is also something that, when you go home after a long day of assessing those people, you ask yourself, sometimes you feel like your decision is going to be clouded by the traumatic nature of the act that was committed by a mentally ill person. Like, yeah, this one is going to be tough because indeed this person is mentally ill. But the child, we're thinking about the child. What kind of future is this young person going to have? Being raped or sexually assaulted at such a young age. So those are the issues. So every time I come back from doing the forensic assessments, I'm drained.
Yeah, I can imagine.
I want to go.
How do you take care of yourself? That's a big question.
That's a big question. I need dance therapy because I love dancing. I cannot dance to save myself from anything, but I love dancing. I've got a 4-year-old. We dance to TikTok videos, dance challenges, and so on. So, but at that moment, honestly, when I come back, I don't want to talk about anything pertaining to my work, what I do. So we dance, we watch the kiddies shows on TV. She loves Nastia so much. Then we can watch Nastia. We can watch planes on the YouTube videos of planes taking off from Melbourne. And she loves Air France. There's a video on YouTube of Air France dancing. I mean, it's those photoshopped videos, but it's dancing like that. And then she'll be like, I want to see the dancing Air France, Mama. And then we watch that. So that helps me a lot.
Going back to normal life and to play and dance.
Playing and dancing and just becoming, just unwind. Yeah. You see, yes.
Well, thank you very much. Is there anything you want to share about your hopes for psychiatry here, for your country, or what message would you like to give us, maybe?
My concern with psychiatry, and especially in South Africa, in the South African context, is that psychiatric patients are stigmatized. The stigma is the biggest problem in South Africa. So you still get those patients that would say, Doctor, please don't write me a sick note. I'll get it from my general practitioner. Because at work, if they see that I'm seeing a psychiatrist, they're going to stigmatize me, they're going to label me, you know, so people still do that. So, and that is the problem. It has improved significantly over the years. I've been in private practice since 2012. So I've seen a very significant improvement with regard to that. But it's still there. The stigma is still there. People are being stigmatized. And I would like people to understand that there is no proper health, physical and everything, without proper mental health, because this is the engine. The brain is the engine that controls your whole body, how you think, how you reason, how you plan, how you organize yourself, how you look after yourself. But over and above that, if you have anything going wrong in your brain, we have seen people presenting to us in wheelchairs, not able to walk. Like literally, this person cannot walk. They've been to the physicians, they've been to neurologists, they've been to the occupational therapists. They can't find anything wrong. But this person is wheelchair bound because of what? Depression, severe depression. So I wish that everyone in South Africa can just understand that everyone, including myself, need to take care of their mental health. It's very, very crucial. It's very important. Without that brain, everything else can just shut down. So if they can understand that, I'm happy, and that is what I push every day.
Thank you, Rose. Oh, that was a pleasure to have this conversation with you.
Thank you so much. It was a pleasure and an honor and privilege to be invited to your show, your series.
Thank you.
Thank you.